Dear colleagues, welcome to EHJ Today. I'm Filippo Crea, Associate Editor of the European Art Journal, and I'm in London. The occasion is the annual meeting of the European Society of Cardiology. I'm sitting with Professor Kaitani from Japan and with Professor Zrenner from Germany. Professor Kaitani has just presented in a hotline session a very interesting trial of pharmacological treatment after catheter ablation for atrial fibrillation. He will discuss with us this trial, and Professor Zrenner will make his comments on the trial. Can we start with the background of this trial? Why did you run this study?
First of all, thank you, Filippo and Bernd. In the EHJ trial, we focus on the short-term empirical anti-arrhythmic drug after AFib ablation, because transient atrial tachycardia occurs frequently immediately after a few months after ablation. So, a previous study showed that the early recurrence is a strong predictor for the later phase recurrence after AFib ablation.
These were patients with chronic atrial fibrillation, paroxysmal, or both?
Yeah, both.
Both. And which treatments did you test in your trial?
Usually we use radiofrequency ablation with PB isolation. Mm-hmm. So basic ablation strategy is a PB isolation. Okay.
What about pharmacological treatment?
70% patient received the class 1 drug and 25 patient class 3 drugs.
Mm-hmm. Okay. And Professor Zrenner, do you have comments about the design of the study?
Yeah, I think the design is appropriate. There is one programming error from the randomization program that led to a significant difference between the two groups according to age of the patients and also related to the CHET score. But the major ablation criteria, as well as paroxysmal or persistent or long persistent atrial fibrillation, are non-significantly different distributed along the groups.
Okay. And what are the main results of your study?
The first primary endpoint is atrial tachycardia recurrence at 1 year with a ranking period of 19 days, and the secondary endpoint is atrial tachycardia recurrence during treatment period of 19 days. If you look at the secondary endpoint first, free rate at 19 days was 59% in the AAD group and 52.1% at the control group. There was significant difference between the two groups. Relative risk reduction rate was 14%.
Can I ask you whether this was clinical recurrence or was assessed by Holter monitoring?
Yes, with a mandatory user recording at home, 3 months, 6 months, and then 1 year.
Okay. Any comments about this main finding of the study?
Yeah, I think this is something we should expect on the first run, that some antiarrhythmic therapy, even after ablation, is helping to avoid, at least in some of the patients, relapses. The question itself is very important because many hospitals, many colleagues use this kind of strategy to keep a therapy for 3 months, no matter how the ablation was successful or not, primarily, up to cover the patients for the blanking period. So the question of this study is, I think, a question we have to have an answer on.
Main finding of our study, for the if you look at the primary endpoint, there were no significant difference between the two groups.
Mm-hmm. Okay. With regard to the primary endpoint, what difference was related to the secondary endpoint? And can you tell more about the mix of drugs used in patients randomized to medical treatment?
Yeah.
which antiarrhythmic were mainly used?
For safety principle, for safety first principle, actual choice and the dosage of the antiarrhythmic drug was left to the discretion of the attending physician. So 75 patients received class 1.
1C.
Yeah. 25 patients received class 3 drugs.
Okay. And also, did you use also combinations of 1 plus 3?
No.
No, just one.
Just one.
Either class 1 or class 3. Comments about it, you think this is appropriate?
Yeah, there was a 75% use of class 1, and some of the drugs are not available in some countries. So, for example, in Germany, the drugs that are available are flecainide, which is given in this study, propafenone, and then we, of course, would have a higher usage of amiodarone, which was, I think, about 6% used in that study. So the kind of drugs that were used would be different in many countries in Europe.
Okay. And what about side effects? Of course, when we propose the treatment, we want efficacy, but with an eye on side effects. Did you find difference with regards to side effects with two populations?
As I mentioned, major patient received class 1, so there were no significant, there were no serious side effect event. However, actually evident side effect requiring exchange or discontinuation antiarrhythmic drug was observed 4.1% patient. But this rate is quite less than
And one of the concerns with antiarrhythmic treatment is the pro-arrhythmic effect, in particular with class 1C. Did you have any signal of pro-arrhythmic effects of your drugs?
Yeah, most described drug was flecainide. This the drug is available in Japan. Flecainide is a pure sodium channel blocker. So no QT prolongation.
Okay. Any comment on this point?
Yeah, there was a low usage of sotalol, where we would expect a much higher rate of pro-arrhythmic events, and at least there were no ventricular arrhythmias mentioned in the trial. Maybe there's a low dosage of flecainide compared to the usage in our country, because the mean dosage was 100 milligram a day. That is probably a little bit low according to our dosage. We would at least use 200 a day.
Now, based on your data, you would suggest antiarrhythmic treatment in all patients undergoing catheter ablation, and how long for, based on your experience in previous studies?
Yeah, that's a good question, but I can't precisely mention answer to it. But previous study, 5-year study, prescribed 6 week, and AmioCat study prescribed antiarrhythmic drug 8 week. This in our study prescribed the antiarrhythmic drug 3 months. But this study is completely consistent.
Can I ask our discussant as well, what will be your attitude based on this study and previous? Antiarrhythmic treatment in all patients, how long for, and which ones in particular?
I think we all like to have sinus rhythm after ablation. We all try to do our best, and sometimes we thought giving antiarrhythmic drugs in this so-called blanking period, I don't like that expression at all, because the patient suffers anyway. It is not a blanking for him. Maybe it's a blanking for our result. So we also want to treat them well. But the result of this in other studies, the AmioCat trial and the 5S trial, shows that routine therapy with antiarrhythmic drugs after ablation seems not to be justified.
Okay. So what do you expect for next guidelines on this particular point?
A change. Just a change.
Okay.
That means routine is really not justified to give an antiarrhythmic drugs, whereas we should clearly make our mind up which patient should be treated with which drug. And this is something that is, of course, also not rulable for all countries, because in Japan there are other drugs in usage than in Europe or in the United States. But the main issue, I think, is to treat those patients that are unmasked by either symptoms or the ECG having AFib or symptoms, and those should be treated, but not all of the patients that we ablate.
A selective strategy based on
Selected strategy, yeah.
Okay, thank you very much for your kind participation.
Thank you very much.